I'd like to introduce today's first panelist, Dr. Mike Gittleman, past Ohio AAP president and medical director of the Stewardship Program.
Thank you, Judy. So I get to kick off this session, and I'm really excited, and hopefully everyone will learn a great deal. Next slide. Thank you. So we have all the speakers have really no financial relationships to disclose or conflicts of interest. Next slide. Our objectives for today are really to learn a little bit about the Stewardship Program, why it's essential, and that's going to be mostly what I'm going to speak about is why this is so important. We're going to hear real life stories from Logan and Melissa, and they're going to share some personal experiences. Emily Harris is going to talk a little bit about how to understand coping skills and resources. And then Sarah's going to talk about our Ohio AAP resources and how you can use them in practice or in your communities. Next slide. So these are our speakers that I just mentioned, and you'll be hearing from each of them today. Next slide. So I think it's important to start with a case. So, this is a case that unfortunately happens all too often. It's about a 15-year-old who presents to the primary care provider for a well child visit. They arrive to the well child care visit really they can get their sports physical completed. During their visit, anticipatory guidance was discussed. They recognized that the child was a bit overweight, so they talked about obesity prevention. They talked about sports readiness because they were getting their sports physical completed. They talked about driving safety because the child was about to turn 16. And they did a heads assessment looking at home, education, activities, etc. Unfortunately, there was no mention of home firearms or lethal means storage, and there was no discussion of recent stressors or coping skills. Next slide. Unfortunately, as this case progressed, EMS presented to a child's house because they heard shots were fired. And unfortunately, this 15-year-old was found dead with a single gunshot wound to the head, and they were pronounced dead by EMS upon arrival. Next slide. So what can we learn from this? Well, the family had a firearm stored in the nightstand next to their parents' bed. The teen had a stressor where they just broke up with their girlfriend that evening. The teen was incredibly impulsive, and using the heads assessment, they uncovered that there was a slight decrease in grades and the child did have some stressors, but it just wasn't really discussed at the visit. Next slide. So I always think it's important to take a look and say, is this a problem or not? And just take a look. So when you look at deaths due to and the reasons why, and you look at different ages, when you're looking at teenagers, unintentional injuries continue to cause the greatest number of deaths. But then look, unfortunately, suicide is now the second leading cause of death for teenagers. Next slide. And if you take a look at these leading causes of death and the mechanisms, unfortunately, look in the teenage years, the ones that are circled, unintentional motor vehicle collisions are always number one, but look at 3 and 4 are firearm-related deaths. Next slide. And when you take a look at our country compared to other countries, the United States accounts for 91% of children killed by guns in all high-income countries. So this isn't something that we cannot prevent because other countries seem to be doing a great job. How can we do a better job within the United States? Next slide. And when you take a look, so I think it's important to look at some of these numbers that this is an astronomical problem. So for the clinicians that are on this and they see this every day, this might be new information for the non-clinicians. But if you look at deaths alone, they're up close to 50% since 2013 due to suicide. It's about 1 death every 3 hours. And if you look at, unfortunately, even younger kids are committing suicide, where there's an 80% increase in children less than 14 years of age. And then you want to look at non-fatal injuries. Since 2007, ER visits are up about 329%. I can tell you within my own emergency department, when I started about 25 years ago, we had about 300 visits a year for mental health problems. We have about 700 to 800 every month right now. And all mental health disorders are up about 60%. Next slide. In Ohio, it's no different. So when you take a look at suicides in Ohio, we have an increase of close to 28% of suicides in Ohio from 2010 to 2019. And you can take a look. This occurs all throughout the state. It's not isolated in just one region. It happens everywhere. Next slide. When you look at gun ownership, about half of homes have a firearm, which accounts for about 200 million guns. In Ohio alone, about 37% of families report to have a firearm, and unfortunately, close to 50% keep them unlocked and available to children. And sadly, of the youth who completed suicide by firearm, 82% used a gun from the home. Next slide. And it's really important for you to recognize that this is not just children with mental health problems. If you survey teens at any given time, 25% of teens are depressed. And so at any given time, if you poll them, a child will have symptoms of depression or anxiety. And as a result, it's not just labeling kids with psychiatric diagnosis, it's really all teens that we have to be concerned about. Next slide. I figured I would just give a 1-minute blurb about, I have my own personal story, and, you're going to hear about Logan's and Melissa's later on. But, my son was, he's 24 today. He was always a little bit quirky. He had decent relationships, and he was a good student, cross-country runner. And after he broke up with his girlfriend, he spiraled and had a lot of problems. We had many nights where he was up all night. He was expressing thoughts of wanting to hurt himself. And as an ER physician with every resource available to me, I still had questions of where do I go? Do I go to the emergency room? What do I do when he has these outbursts? What are some of the coping skills that I can work and work with? So hopefully today, when you hear from Emily and you hear some of these stories, some of these might touch home to you, and hopefully you'll learn these resources of what you can use if you have this situation or you have a friend or neighbor with this situation. Next slide. And the bottom line is the store it safe is important. We need to keep lethal means out of the risk of teenagers. When you look at the time elapsed between decision and attempt, they interviewed survivors and they found 25% made an attempt within 5 minutes, 50% within 20 minutes, and 71% within 1 hour. So if you think about it, if we can make it so they don't have the lethal means within that 1 hour, and we can work on these coping skills, we could make a difference. And that's really the basis for the Steward Safe program. Next slide. So the Steward Safe program, we brought together a lot of groups. You're going to hear more about this today. Next slide. Even in Akron, we have billboards up. So we're really trying to spread this throughout the state. And so we really appreciate all of you being and listening to the stories and understanding what our resources are so that you can spread this and we can get this word out to everyone. Next slide. Well, I'm also honored to present our next two speakers. We are so thankful to be able to hear their stories and to learn from their experiences. Logan Crick is going to present their story today, and I cannot wait to hear what Logan has to say. Next slide, or to Logan.
Hi, I'm Logan Crick, and when COVID started, I was a cisgendered heterosexual girl. Now I'm a pansexual transmasc who uses he, they pronouns. It's very surprising, like all the events that had happened, because most people only talk about the bad, but there are some good things that did happen, although it's not really touched on as much. But before COVID happened, my mental health wasn't the best. I was struggling, but I knew that it wasn't to the point where I actively sought out help. During my freshman year, I started questioning things about myself, my sexuality specifically. I was diagnosed with anxiety and depression and had friends, but not very many good ones, and I still felt like an outsider. Nothing I did really felt like the right response. My sophomore year, I figured out that I was bisexual and I had found some new friends. I even got in my first relationship. However, then COVID hit and I isolated myself because I didn't know what else to do. I lost all my friends. I got broken up with over text, nonetheless, and was really struggling in all my classes. My parents had both kind of shut down, and so I felt like I had to take care of my siblings. And so I did that. I cooked them meals, I put them to bed. Sometimes I'd wake them up and I made sure they did some schoolwork. I didn't like micromanage them and make them do all of their homework because I still had to focus on my schoolwork. And then I started questioning my gender and sexuality again. I was trying to find myself and keep everyone else afloat, and it was a very lonely experience. I had started social media just that year, and I was trying to find validation from people who I didn't even know like where they lived. Um, I had one friend that I really talked to a lot, but eventually that friendship grew toxic, and I realized that they weren't really helping me; they were actually hurting me. I came out as gender fluid and as Logan on social media, and I hadn't told my family because I was still trying to accept and understand it myself. However, I did forget that a good amount of my family members followed me on Instagram, which was where I like changed my name and everything. And one of them told my parents, and this was very detrimental. It caused me to go down like 3 different steps, like I was spiraling. Um, Something that's very important is coming out is something that the person who it affects, like it's very important. There's a movie called Love, Simon, and Simon was outed by someone who was trying to blackmail him, and he says, I'm supposed to be the one that decides when and where and how and who knows and how I get to say it. That's supposed to be my thing, and you took that away from me. These are honestly some of the most true words I've ever heard, because coming out as who you are, you should be able to decide. You should be able to tell the people who you want to know. You should be able to hide it from people like who you just aren't ready to tell yet. But I unfortunately did not have this opportunity. And it kind of took like everything away from me. I didn't have any more sense of security. I kind of felt like everything was just gone. I had gotten TikTok a little earlier that year, and I used that as a way to boost my confidence because I have pretty crippling self-doubt. And it was really nice to have that because a lot of people who were on TikTok did like support me. And so I felt I had a place to get away, even though like my real life was not the best. Something that I do want to touch on is that a lot of people like to interchangeably use sex and gender. And I want to put it out right now that gender is very different from sex, and sex is biological. It's like X and Y chromosomes, and then gender is who you are, who you identify as. It's can be the same, and it also cannot be. And it's kind of it really hurts when people try to use them as the same thing as a way to attack someone. I knew that hate was a part of coming out, and I was prepared for that, but I wasn't prepared for the hate that would come from people I didn't expect. There was a lot of people who didn't accept me, and I lost a bunch of friends when I came out. I got reprimanded by a bunch of people, and I even got told that I was going to go to hell because of my sexuality and my gender expression. This went on for a long time, and nothing really changed. And then school started, and I made some friends that I could talk to in classes, but I knew I wouldn't stay friends with them for very long, and things kept getting worse. And then one day it just became all too much. And on October 27th of 2020, almost a year ago, almost exactly a year ago, I attempted to end my life. And I realized what I had done before it went too far, and I got help. Reaching out was honestly one of the hardest things I've ever had to do, because I've just never had to reach out in that way before. I've always needed some help on schoolwork or something, but reaching out for something that you can't really change was terrifying. And I really just didn't want to burden people. I didn't want to be judged. I didn't want to bring them down, and I thought I could handle it myself. But it turns out I didn't. And getting help was one of the most important things ever. And more people, we need to destigmatize it, because that's one of the main reasons why people don't get help. They're afraid of being judged. They're afraid of being called psycho and crazy, because they don't understand. A lot of people don't understand that people do understand what you're going through. And honestly, even though COVID was one of the worst experiences ever, I probably wouldn't change most of it, because it's helped me figure out who I am. I learned how to be more confident in myself. I learned to express myself unapologetically. And I've also learned how to deal with hate, which is something that pretty much wherever you go, you're going to have to deal with. And so even though those hardships are something that will never be taken away, and I will always have with me, and some of those I didn't really have to experience, I'm really glad that I did.
Logan, thank you so much for sharing your story. I can tell you that I've done this a long time and presented a lot, and I still get a little bit nervous. And you handled that like a champ. So thank you so much for sharing your story. And I really hope that everyone that's listening, learned a little something, and we'll take some of that home. Our next speaker is Melissa Werby Arnold. She's the CEO of our chapter, but she's also a mom of a great boy and a girl. And she's going to tell a little bit about her story of being a parent.
So Logan did an amazing job of not reading, and I do not like to read from paper, but based on this topic, I just really felt to express myself the best way. I'm going to read to you also. I apologize for that in advance. When we started building this panel, we all felt that one of the most important pieces would be to have a parent share their story. So as Dr. Gittleman said, today I'm not here representing the Ohio AAP, but I'm here speaking as a mom. As I sat down at the blank screen in front of me, I've struggled with what to share as a parent of two children who suffered from anxiety and depression. One of them who was recently hospitalized for suicidal ideation. I'm sorry. I am certainly not an expert, and I definitely didn't do all that we will share with you today in terms of what our best practice is. But I hope that all of you, if you're a parent, an educator, a pediatrician, a nurse, or a therapist, can learn a little from me and some thoughts from my children, with the hope that I can help just one person be a little more aware than I was at the time. I don't want to share the intimate struggles of my children's mental health, because that's not my story to tell. My story instead is of a mom who thought she had all the resources, all the tools, all the connections to overcome anything she was handed when it came to her children. After all, their father is a psychologist, their mom works for one of the largest pediatric associations in the country, and I am surrounded by an amazing and supportive family and group of friends. But last spring, I realized I knew nothing. I was not prepared, and I certainly had no answers. The morning we had to have my son committed to inpatient treatment still seems like a complete shock and blur, even now, even knowing everything I had learned. That morning was right after Easter weekend. We had an amazing weekend with friends and family. And the next morning, my kids, who were at the time 16 and 15 years old, went to school. It was actually one of the first full weeks back after hybrid learning. And I was thinking we were finally coming to an end to the isolation and challenges of COVID. Around 11 a.m. that morning, I get a text that said, please call immediately. I am taking Connor to Nationwide Children's. It's an emergency. As a parent, many of you probably can know and understand, you immediately thought if something physically was wrong, he got hurt, or he was sick, or there was an accident. But when I called his dad back, it kept going to voicemail over and over. And then I finally received a text. It said, Connor just called me. I'm taking him to the hospital after talking to Dr. Kowach. Connor says he's going to kill himself. Please come to the hospital. Even typing words now, those words now, make my chest hurt with the panic I felt in the moment. Because it was COVID when I arrived, I couldn't go back to the emergency area of the hospital. I could only sit in the lobby. I was there for 5 hours with a dying cell phone and only brief updates to what was happening in the back of the room. I was finally able to have a call with the doctor in charge. They told me they were admitting Connor to inpatient care as they had determined he was at a high risk for suicide. The surreal nature of that moment will play over and over again in my mind. We were working on teen suicide program for 2 years at the Ohio AAP before COVID began. What did I do wrong? What did I miss? I felt I didn't have firearms in my house. I purposely didn't buy Tylenol. And I actually did lock away all the kids' ADHD medications. But when the doctor talked me through the reasons for their determination for inpatient hospitalization, including the extensive suicide plan Connor had planned out, I knew in that moment I had failed my child. I hadn't paid attention to all the appropriate warning signs. I knew my kids were impulsive, and I knew he struggled with ADHD, depression, and his ADHD. But I thought I had done a great job of putting barriers in place. And yet I didn't lock away belts. I hadn't even thought of that as something to be worried about. That was his suicide plan. Before COVID, I spent countless hours in the community talking to funders and members about our Stewardship Program. I knew all the statistics. I just didn't realize my child would be part of that statistic. And now here I was, finding shorts to bring him to the hospital that didn't have any strings in them, changing my shoes since I couldn't have laces in the hospital, and packing up a childhood stuffed animal so he would have a little piece of home in a room that he needed to be locked away in for his own protection. After 5 days, Connor came home. He is now in intensive outpatient treatment that we do 3 hours a week. But there's no magic to therapy or medications when it comes to mental health. Almost weekly, he struggles with depression. And while we work at his skills, sometimes it feels like we take 1 step forward and 5 steps back. It will be a lifelong battle, but one that I see him fight to get better every day. And I'm so incredibly grateful for his will to not only get through this, but he actually wants to be a child psychiatrist himself one day to help other children who have the same challenges as he does. I wish I could tell you that was the end of my story, but instead I will share with you that only a few months after Connor's hospitalization, my daughter Alex came into my room one evening, desperation in her eyes, tears streaming down her face, and when I asked her what was wrong and what I could do, she said, "There is no hope, there is no help. I don't plan on living too many years. I don't want to live feeling this way." The same devastating desperation I had with Connor, I felt all over again. Although this time I was at least a little better prepared. We already had a safety plan in the house, so I knew there was a barrier in place to her and most lethal means. I was also prepared with skills I had been learning with Connor through therapy, but there was a 4-month wait to get her in to see a therapist. I'm grateful that I've always had a wonderful pediatrician who started her on medications to help. And her doctor was at least able to also increase those medications to try to get her through until she could be seen. That 4 months was a long 4 months, and we have just begun therapy. And I believe we have a very long road into getting her into that better mental health state. But I have been able to have small comfort in the fact we follow the AAP guidance on Stewardship Program. And we're going to share with you some new tools today to help in a crisis. There's a line in the musical Dear Evan Hansen that I always find rings true to me when I'm at my lowest in my own mental health, worried about my children. It says, "And I knew there would be moments that I would miss, and I knew there would be space that I couldn't fill. And I knew I would come up short a billion different ways. And I did, and I do, and I will. We will all fail as parents at some point. But though I know the prevalence of teen suicide, and I knew my children had mental health concerns, I wish I would have been better prepared. I can't go back in time, and hopefully that preparation advice, hopefully I can give that preparation advice to others. Store everything in your house safely, not just firearms. Think about a safety plan and talk to your teen about it. And be aware, this can and does happen to families, and you have to acknowledge that as a possibility. As pediatricians or educators or as concerned adults, please be mindful of this issue. We need to work together to stop this trend. My kids know I'm talking today, and they asked me to share some of their thoughts with you as well. They said if your child or a child you know suffers from depression, do not blame your kid. Make sure they know it's not their fault, that they have support. Stop assuming if your child has depression that they are being lazy or not applying themselves in school if they're struggling with grades or peer relationships, because those parents are wrong. Their kids are trying their hardest, but with little or no motivation, it's hard for them. So please just be patient with them. And finally, talk through a plan and pay attention when they say they need help. You might not get a second chance to help. For 19 months, our children have lost their childhood. Before the pandemic, we had a teen suicide problem. And in 19 months, we have seen that issue grow bigger. Since the start of the pandemic, pediatricians are reporting a 50% increase in teen depression. And this is after the adolescent suicide rate had already increased by 56% in the past 10 years. We have lost too many children, and I fear every day for my own children's mental health. But we need to plan ahead and stop the trend of irreversible actions. These kids are counting on us. And I will turn it over to Dr. Harris.
Thank you so much for sharing such an incredibly powerful and personal story. I think the bravery of this entire panel is tremendous, and I'm very honored to be here to speak about this with you. So I'm here to talk about, like, what can you do? Like, what can you do to prepare? What can you do to kind of address this when kids do come to your clinic or families do come to your practice to talk about these things? And I also was watching the chat and seeing that there was a lot of talk about, it's that you weren't a failure, but I 100% would agree that I would have felt the same way. And it can happen to anybody's kids. So let's talk about what we can do. So move forward a slide, please. One of the quintessential pieces of parenting is to keep the babies alive, through nutrition, through safety, through, teaching them to be independent adults. That's kind of what we're wired to do. So kind of thinking about safety, identifying risk. And then when you do identify it, manage what you need to do with it and develop a plan are really the key points of what we're going to talk about. In a safety plan, there's restricting access to lethal means, increasing supervision and communication strategies, but we're also going to talk about something that's not historically included in safety planning, but some other coping strategies that can be used in the moment. Next slide. This is the Store It Safe, at least our initial algorithm for how to address mental health concerns, especially through well-child visits. A lot of this information is based off of the guidelines for adolescent depression in primary care, where they talk about a validated screening tool, and then what to do with the results. Next slide, please. And a lot of us are familiar with screening for depression, and Ohio has actually done a tremendous job with getting the word out about how to look for depression and how to screen. And the more, I think newer screen is about suicide risk. And we're going to talk, there's two validated ones for small children or younger children. And the other one is the ask questions. That is also evidence-based in kids, but we're going to talk about this Columbia Suicide Severity Rating Scale for primary care. And it's a brief screen. More information about this can be found on the CSSRS website. And it actually has, brief trainings, different screening tools. You're going to see a very familiar ring to the screening tools, but then they have some wonderful resources for suicide prevention. And the Columbia in particular is very helpful because it not only gives a script. So like one of the hardest things I think is remembering to think when you're distressed as a clinician. And that's the beauty of these screening tools. It literally gives you a script, much like how Melissa demonstrated. It's much easier to read it and then to actually think about it and generate these questions if you as a person are emotionally triggered by what's happening. So these questions walk through the ideation of suicide, how active it is. And then the one is not, it's not just about have you had thoughts, but then if you have had any thoughts, even if it's not what would be considered high risk in those moments, but have you ever done anything, started to do anything, or prepared to do anything to end your life, as an additional question that's unique to this screening tool. And it's amazing how kids can disconnect the concept of a suicidal thought with actually preparing to do something to end their life. So asking both questions is very important. And it goes through the different rates or high risk levels versus something that you could potentially safety plan home and have them be followed up in the near future with an intervention. Next slide. Whether or not you're trained with how to do this or feel very competent with mental health or psychiatric issues, the most important thing you can offer is hope, empathy, use the same language. Like you're, as the provider, the pediatrician, you're committed to this child's health, and partner with the family, partner with the child. These are all skills that are related to motivational interviewing, cognitive behavioral therapy. Lots of different factors kind of weigh in. And Lawrence Wisso is a pediatrician and child psychiatrist who coined the term common factors and created this help mnemonic that helps guide conversations that are very difficult. It gives you kind of a framework to use. And when someone offers this information to you, like they've felt suicidal, taking it seriously, even if it's mentioned in jest or as a passing comment, the kids are testing. They want to know if you're going to take them seriously or if they're going to, if they should be talking about this with you or not. And just acknowledge like how, just if it was distressing, how distressing it was, or how brave they were for letting you know. But really that your goal, no matter what, is this patient's safety sitting in front of you. And the National Association for Mental Illness is an organization of people with mental illness and families as well that support them. And they came up with these principles or tips on how to engage with teens. Teens are not easy for adults. It's a tough crowd, but it's actually one of my favorites to talk to. But the idea of how to engage them, I think as pediatricians, we often get into a very quick kind of fast pace, and it's easier to get information from parents about what their interests are, and they're the ones guiding the patient's care directly. But when it's a teenager, engage them during the visit. Pull them in, ask them questions directly, ask them about how they want to be communicated with. Often people in this age group don't feel heard. And then offer information. This is like the tool that we have that they need. And especially when someone offers that they have had thoughts of suicide, it's always important to emphasize that there's always a choice and you do not have to act on the thought. Thoughts do go away and you kind of ride the wave of when they come up and when they come down, but there's things that we can do. Next slide. So the idea of safety planning is, it's not a contract, but it's safety planning is to anticipate that bad things can happen, or tough conversations, problems, pandemics can happen when you don't expect it to. And it's so much easier to think when you're not in crisis. When you're in crisis, literally the part of your brain that is functioning is not the thinking part. So now that we're not in crisis in this office right now, let's talk about what we can do should crisis happen. And as Dr. Gittleman mentioned, the suicide attempts are often extremely impulsive. And if you remember adolescent brains, that prefrontal cortex, which is the brakes to the amygdala, the emotion emitter, hasn't quite developed all the way yet. So they're still learning how to make decisions and how to make good judgments. But what we really want to do is help. Some of these strategies are involved to delay the access to something that could be potentially irreversible, but also to arm them with things that they can do to help bring that dysregulated state back down to regulation so they can start using that thinking part of the brain again. Next slide. So with the safety plan, we talk about restricting access. So the first thing, restrict access to lethal means. The lock boxes, I think, are amazing because they hold more than just guns. You can put lots of stuff in them. And you can get different kinds of these things that have locks on it. But the idea is not to create a challenge for the teen or the kid. It's actually to say, hey, I want there to be as much time between you and this thing that could potentially kill you. To give it time for that 20 minutes where half of the kids have attempted, or that hour long where 70% of the kids have attempted. Give it time to kind of bring down that emotional dysregulation. And then offering information to the parents about things that can make that decision-making worse, like alcohol, drugs, anything that can disinhibit a child further. Again, focusing on safety. And next slide. And I think I'm a little bit concerned about my time, but the communication strategies is, it's actually like a contingency plan, so to speak. So your goal is to kind of tease out, if you can, if you have time, to tease out, what kind of triggers are happening, what situations are perpetuating the suicidality or kind of putting the child at the highest risk, and asking kids very directly, like, what was going on the last time, and did you tell anyone? Does anybody know? How did it stop? I think Logan did a wonderful job of what we would consider to be a self-interrupted suicide attempt. Like there was something there that made them stop, and then asking, like, what helped you make that decision? And that was a life-saving decision that you made. And there's lots of protective factors that are usually pulled out when kids offer that information, because that's going to be critical to developing a very specific safety plan for this child that's going to be helpful and meaningful. The idea of name three. Some people are familiar with like 3 people they can go to. Often the kids will say the parent or the caregiver in the room, and it's important to make them think outside that box, because that's a very socially acceptable canned answer. And it's usually, or sometimes the parent or the caregiver that's implying the rules that is triggering the distress in the first place. So you have to kind of make sure that they're able to kind of come up with more than just one person. And if they can't, there's some resources at the end that we can go over as well, or at least be introduced to. And then the idea of like, just, okay, so what if you're at your friend's house? What if you're at school? These are conversations to have like with the patient, but also with the family too, you can have as well. And there's some more resources too. Go ahead and move forward. So the pieces that are involved with kind of the overall plan. So we have the safety plan of the restricting lethal means, increasing the adult supervision, and coming up with communication strategies. The other parts of this management is like identifying those impairments, either, from, you can advance it. I think it actually has some pieces. Just go ahead and go for it. Yeah, there you go. Treating anxiety and depression and poor impulse control, because as we know, depression is not the only thing that leads to suicide. Maybe 30 to 40% of the cases have that being the primary mental health diagnosis. Helping them with positive coping strategies, I think, is going to be the biggest preventive piece we can do as pediatricians and as parents and caregivers of kids. Helping them with this emotional regulation piece, helping them with depression, doing one thing that they can do to help their brain recover, because it's a disorder. It actually is causing a tremendous amount of dysfunction and impairment, even anxiety, impairment in social functioning. And social functioning, that connectedness is such a huge part of improving and protecting yourself from the risk of suicide. Integrating how to manage distress, but actually specifically asking the kid, what would be an ideal way someone could help you if the thoughts of dying return? And often kids tell me that the parents are asking them every 5 minutes, are you okay? Are you okay? Are you okay? And that may not work for that child. And so asking them, what would actually, having the parent or the caregiver with them, what would be helpful for you, I think is a very powerful way to kind of get a very effective safety plan. And the idea that it can change over time, like having a text system, having a thumbs up system, having a journal, something like that, that is just creatively outside the box, is really where the kid is going to be the expert. And sitting in, asking them to sit in the room, not be isolated. So when you're isolated, it reinforces the suicidal thinking, because there's just nothing to distract you at that point. So what can you do instead? You can have the door open. You can have just be able to go in a room and sit down, not have anybody talk to you, because again, you're distressed, you're dysregulated. You don't want to have a lot of questions asked of you at that moment. You may not even have the words, which is 90% of the time. And kids don't know how to articulate what is going on. They just need somebody there. And the parent and the caregiver is such an important buffer in those situations. And knowing the child, knowing when they're kind of feeling okay and thinking again, it's I really like that you sat down with me. And if there's anything that you want to talk about, I'm actually curious, what do you be interested in what they're thinking about, be interested in what they're interested in. Next slide. Some of the great self-management things that one of the Stewardship Program offers that Dr. Denny's going to get more detail with is, what do you do as a parent, but also as the kids themselves, if they're having thoughts, how can we teach them healthy coping strategies to manage distress? Distress is never going to go away. It's how we approach it is what we can change. And having these different techniques, there's a myriad of techniques, but this is kind of what therapy, a part of what therapy is doing, is helping you understand how to get back to that regulating brain piece and how to have these different strategies to approach it. And rhythm is incredibly important. Repetition, rhythm, predictability. These are all things that kind of bring us back down. That's why music, I think, is one of the most powerful coping strategies on a fundamentally neuropsychiatric level. It's amazing. The idea of the senses is another grounding component of, it's not just distracting, it's just helping you focus on something that you can do. And it just brings down the dysregulation, which helps you get back to that thinking brain again. Next slide. And I did talk about it a little bit before, but I wanted to just bring attention to, these are the factors of resilience. The pandemic has literally crossed out most of these resiliency skills and opportunities for kids. So I think just recognizing that, all of these healthy coping strategies have been shifted and adjusted and smashed with COVID. So we being creative around it. Anytime you notice when a kid is making a good choice about connecting or trying, I heard Logan talk about parenting or feeling like they needed to parent their siblings. That was amazing that was your instinct. Bravo for taking care of something, because that's incredibly important, especially when we're isolated. But thinking about ways to keep the brain healthy. That's what pediatricians can do. You need sleep, you need to eat, you need to connect with people. Those are baseline skills. At the bottom of this slide is a link to Just Breathe, which is about 4 to 6 minutes. And it's a wonderful introduction to why the deep breathing and how, literally how to get that calming pathway activated. Next slide. yeah, this is my last slide about the different resources. I think I imagine at this point, Logan, you've heard about Trevor Project, and if you're not, please, the Trevor Project is going to be an amazing resource as well. Has really safe chat rooms that are designed for kids that are in a community where they are openly rejected and terrified to come out, or if they just need support. It's a wonderful place. There's also, the National Suicide Prevention Lifeline. This is actually a website I go to for these talks, and I keep going down rabbit holes of information because it's like so much great resources at your fingertips. These are like the phone numbers in the text that you can literally put in the kid's phone in your office before you even bring the parent in the room, is recommended. But on the website, you have the Trevor Project, stopbullying.gov, use suicide warning signs, lots of great information available. And with that, I want to pass more of this over to Dr. Denny.
Great, thank you so much to all the panelists for sharing their story, their experience, and for just being part of this really important conversation. I want to call out one key thing that Dr. Harris mentioned is that people who commit suicide don't necessarily have to be children or adults who are depressed. And so I know we have a lot of different people who do a lot of different jobs who are participating today. And sometimes, we think, well, not my kid or not my student or not my friend, but we have to realize that it is an impulsive decision. And so when we're talking about screening for depression, we're also going to talk about how it's important to be screening for suicidality in addition, because we want to make sure that just because we haven't identified someone as having depression, they still could be at risk of suicide. And so we want to make sure that we are screening everybody. So I am going to just walk us through some of the materials that the Ohio AAP has worked with several different partners and youth to develop to provide some of the content that we've talked about today in a more easily packaged mode of delivery. So next slide. First thing is our webpage, and this is at the Ohio AAP Store It Safe, and you can see that there's some information about Store It Safe. There's provider resources, there's parent resources, there's resources for teens. There's also education modules, and we'll go into each one of these in a little bit more depth here, but I just wanted to show you where you can go, and anyone has access to this. You don't have to be an Ohio AAP member, you don't have to be a pediatrician. This is available for free, it's available to download, it's available to post on social media, and so we encourage you to do so. As Logan mentioned, destigmatizing this conversation is critical, and we all play an important role within our community on that. Next slide. Okay, so one of our action items for all of you who are participating and have been moved by this conversation, take a minute to share something out on social media today about reversing a trend of irreversible actions. These are some digital images that you can share out on social media. There's also a QR code that you can see there, and that's something that you can have your patients, your students, save those images to their phone, and there's information on resources, whether they're in crisis in the moment or you're trying to plan ahead. Those are all available. Next slide. All right, next slide. Okay, perfect. So we have some provider resources. These are for healthcare providers who are taking care of adolescents, just around how to have that conversation. Sometimes it's not an easy conversation to have, talking about firearms, talking about lethal means, talking to parents who are kind of still in that not my kid's space about how important it is to have these conversations. Next slide. On the back of this is just a one-page document. There's a sample pathway as to how in your office can you make this just standard, screening for depression, screening for suicidality. And as with any screen, once we screen, what do we do with those answers? And so this is a really nice algorithm that helps guide you through that process. And so again, this is available. Just to put in a little plug, if you are interested in implementing this in your practice, we are currently recruiting for a quality improvement project, and we will help you do this. So I would definitely encourage you to reach out to the Ohio AAP if you have any interest in participating in that quality improvement initiative. Next slide. And then also, we know young kids are curious and they don't understand danger. We know that if No matter how much we teach them about the danger of guns, if they see them, they are going to play with them. It's very well documented. So protecting the younger children and having those conversations at your younger child will visits is important too. So a document more geared towards those younger child visits. Next slide. Okay, so for our parent resources, Ohio AAP members, you did receive these parent resource rack cards in your conference in a box kit. But for those who are non-members, again, this is available on the website, and it's just a really nice guide to 3 steps to plan ahead, talking about, oh, I'm sorry. This is actually the one pager that we have on the website. Next slide. And here is the parent card that I was referring, or that's the back of the handout. And next slide, the parent card, very good. And one more slide. Great, so there's the handout as well as the rack card. The rack card also includes that QR code that I was referring to. That is just a really quick and easy way to have all of these resources provided in one spot. Okay, next slide. And I think one of the really important pieces of this conversation is talking to teens about talking when you're not okay. It's okay to not be okay, but let's have a plan for when you're not okay. And we also have to recognize that sometimes teens are put in a position where one of their peers is not okay and they turn to their friend, and now all of a sudden your teen is trying to figure out how to navigate this really new and scary situation. And so we've worked with our mental health providers, we work with our teens to come up with this rack card designed specifically for teens. We know that teens are more likely to text than they are to make a phone call, so we include the text line. We talk about, restriction to lethal means. We talk about what to do if your friend does mention that they want to hurt themselves or that they're not okay. Next slide. And so the back also continues to talk, some of those things that Dr. Harris mentioned. The 5-4-3-2-1 is a fantastic strategy. Just listening to music, taking a walk, doing something to just get back to that deep breathing, that calming, to try and get through that period of really high intensity crisis and onto where we can start employing our coping mechanisms. Next slide. So we also have on our website education modules. They're pretty brief. The first one is just kind of an introduction to our program of reversing a trend of irreversible actions in the Store It Safe partnership. Next slide. We also have one specifically related to the younger children. Obviously, it's a different conversation. We're talking about preventing access of young children to firearms as opposed to our teens. And next slide. And then lastly, a lot of what we've covered today in this discussion is covered in the module for the teens as well. Next slide. So I want to say a huge thank you to our foundation who helps fund the gun boxes that we provide, our community partners who are participating. I know we have educators, we have all kinds of community partners, the providers who are participating, but most importantly to Logan and Melissa, because this is real and this happens, and it happens to our friends and it happens to our families, and we have to be ready and we have to continue these conversations. So I just very much appreciate everyone's participation. I can see that there's been a lot of commenting in the chat box, so I'm going to turn it over to Mike, and he's going to moderate the question and answers.
Wow, so the presentations were outstanding. I think one of my take homes from this is, as a clinician, you always want like a cookie cutter approach. You want to say, oh, if someone has this problem, here's how you handle it. And when it comes to this situation, there really isn't one. Like, everyone presents differently. Everyone's experiences are different. And the most important thing is for all of us to recognize it, ask some questions, and really, when we recognize problems, know what's available to you. And I think this program does just that. So how much time do we have?
Plenty.
Okay, so we have plenty of time for questions. And I have a couple questions that I think were put in the chat box that I will put forward to the panelists here. So first question is, what are the pros and cons of social media when you're addressing mental health issues?
Well, I think that's actually probably a generational answer. I would imagine that there are long lists for both. But what I did hear that we have to remember too is that that is one of Logan's strategies that they used to improve their confidence and feel safe. And I think it's an interesting double-edged sword because they're also at high risk of being exposed to things that are not okay. And how, you know, especially with this like cancel culture and this concept of, you know, likes, not likes, like these really quick, literally impulsive decisions kids are making that determine someone's worth is a concern that I think most adults have with this type of media. But I think, again, talking to the kids, asking the kids like, hey, what's going on? What do you tell me about this? Like being interested in what they're interested in is going to be the best way to kind of address if this is going to be a con or a pro for this too. But that's a tough question, and I am not an expert in social media, but we all, I mean, all of us talk about it. Know what your kid's looking at. Yes.
All right, the next question is, what are residency programs doing to train future physicians on mental health issues?
So I can start, and Emily, if you want to chime in. I think that obviously that varies by program, but I think that there's a lot of acknowledgement about the role that mental health plays in primary care, in wellness, and both of the providers and the patients. And so I think that it's become a much more significant component of training, not just talking about it, but screening for it, knowing how to treat it. I mean, let's face it, there is a lot of anxiety and depression management that occurs in the primary care setting because of the wait that Melissa mentioned to get in and see a therapist. So it really is our responsibility to help manage some of those things. So I definitely think that program dependent, but it is a key component of the training.
I also think that it's important for wherever you train to recognize, how do I screen for this? And then what should I be talking to families about? And your resources might be different. And so that's okay if you have different resources that are available to you, but just being able to recognize it and know how to act upon it. And when families have questions, what are your responses? I think every trainee should, if you're not getting it in your program, then there's a lot of other resources to learn about it.
Just to think about this really quickly, it's actually interesting. The trainees are a lot of the motivating factors with system change around the burden of responsibility to shift more broadly to pediatrics, and not just in primary care, even the emergency rooms with the safety evaluations that are happening and how to address it, approach it, and talk to kids. Specialty clinics with chronic illnesses, these kids are at higher risk of not only anxiety and depression, but anxiety and depression that's untreated, having their health outcomes be poorer because of the untreated illness. This is like not really a rotation. It's pretty much like an everything. So a couple of years ago, I put a poster up that Dr. Doobie and helped me kind of write up about it, but it's really these opportunities that are hidden in all of these rotations that have mental health learning opportunities that are there. And we're kind of working on it because honestly, you guys are the preceptors. So if the trainees want to know about it, you got to know about it too, to help them, coach them on how to do this. So there's a few programs statewide that are happening. Building Mental Wellness was a beautiful one back in the day. But now we're kind of moving into an ECHO model, at least on a children's, that offers this ongoing coaching. It's a little harder to learn than just watching an hour-long video or doing a workshop. That's not how we learn in psychiatry. So I wouldn't expect you to become a master after a lecture. So ongoing coaching is key.
And I would just add too, because we have a lot of educators in the audience, I think that many of the school districts have done a fantastic job because the educators are with the students. You know, day in and day out, and they notice things, whether it's the student's affect or chronic absenteeism, that some may be a sign that something else is going on. So I know, some of the school districts use SOS, some use mental health first aid. If your district doesn't have some sort of training for educators, I would definitely encourage you to do that, because I really feel like our teachers are on the front lines and really able to recognize and potentially link with appropriate resources if something were to present itself.
All right, and I think I have one last question, which is, what's everyone's viewpoint on co-location for mental health services? So having mental health services in areas where you work.
I will take that one. I am so fortunate that I work in a clinic, and we actually don't call it co-located, we call it integrated, because our psychiatrist is integrated. She sits next to me in my clinic. If I am seeing sick visits and I think, gosh, I think this child's abdominal pain that only happens Monday through Friday when they go to school might be anxiety related, I can pull her into that visit right there in walk-in clinic, and she can go in and troubleshoot with the family. I think it's an amazing way to, in the moment, address issues and work on problem solving with the family. Working with the school. Okay, don't send this patient home every time they have a bellyache. We can work on some strategies to keep them in school and get over that component. So I think that if it's available to you, it is an amazing, amazing resource. And I learned so much from our psychologists in our clinic too. So I'm a huge fan.
I think it's great. But it actually makes my job easier because you guys can, even at the school, you were mentioning it with the teachers being aware and having them have a resource that they can refer to and do a warm handoff is tremendously powerful for the kid. The families kind of think we're already doing this. Mm-hmm. So to have it in your office is tremendous. And, as the medical provider, the therapist is extremely helpful to even approach things on that continuum of mental health when it's at risk. Like the superpower of pediatrics, I often say this, is approaching prevention, immunizations, we do this, and also intervening when you notice the risk before it becomes a disorder. You can drop PHQ-9 scores tremendously by giving these coping strategies, cognitive skills, different CBT, these evidence-based interventions in the moment works. It's awesome.
Well, so thank you for all of our panelists and the discussion today. I think that I will at least end this with, we have a lot of really great resources. And so please visit our website, share with social media and your friends. And I really think that, knowing about it and being able to address it and have the resources in your hand is really helpful. And so hopefully these resources will help. I am now going to turn it over to Alex, and we're going to do a couple polls, and we really hope that you guys will participate in the poll. It's going to help us learn a lot more about what are the resources we need to put together and how we can assist you in the future.
So the first poll is, how will you engage in the Stewardship Program? And there's some options. We'd just love to know how you all plan to be a part of our work. And we will share the results in just about 15 or 30 seconds. So share. You can click as many of these options as you plan to participate in.
You ready? Should I click on? Ready?
So thank you, everyone. So we can see our results for the first poll. Most people are interested in distributing printed materials or sharing some of this with your colleagues, discussing directly with teens. So very exciting. Thank you. It looks like we have some great options. How about we launch our second poll? And the second poll, which audience do you believe will most discuss, the Store It Safe program with? So do you think colleagues, parents of teens, teens themselves? How do you feel you can best reach with this information? And we'll give you about 30 seconds. All right, thank you, everyone. So parents of teens is the clear winner of this poll where we can share information. So about 2/3 saying parents of teens, a little bit less for teens themselves. And then how about our final poll? Which resource do you believe will be most helpful? And this is really great information for us to be able to know what we can do next. So website, mobile social media images, printed rec cards, or trainings. Which of those that were shared do you think will be most helpful? And we'll give you a moment to answer those. All right, and then our final answers. So looks like training for providers is the most popular, but printed rec cards and the website will also be helpful. So thank you for everyone who answered. This is great information and we really appreciate that. We can go ahead and advance to our next slide. And we're going to throw it to Dr. Chris Peltier in the upper room here for our close.
Thanks, Haley. For those of you that don't know me, my name is Chris Peltier. I'm a general pediatrician in Cincinnati, and I have the pleasure of being the president-elect of the chapter and serving over the child health pillar, which is in charge of this meeting. So I just want to take a moment before I give it back to Dr. Romano to just thank our panelists, our physicians, Dr. Denny, Dr. Harris, and Dr. Gittleman, but most especially our two special guests that really just so bravely and incredibly shared their stories. So thank you both to Logan and Melissa. We really appreciate you sharing your stories with us. And I just want to thank everybody for their support and those of you that donated to the raffle to support our Store It Safe program. We'll have a couple of announcements in a little bit, but now I'm going to return it back to our foundation chair, Dr. Romano, to wrap things up. Judy?